Urbanization is one of the leading global trends of the 21st century that has a significant impact on health. The rising non-communicable disease burden, the persistent threat of infectious disease outbreaks, and an increased risk of violence and injuries are key public health concerns in urban areas. Good day, I am Dr. Penny Adversario, and for this learning session, we need to define urbanization and industrialization, identify the positive and negative effects of industrialization on healthcare delivery, discuss the health outcomes or consequences from these negative effects, its risk factors, potential socioeconomic impacts, prevention, and control. Let us begin by defining urbanization and industrialization. Urbanization is the shift of population from rural to urban areas, or a change in the ratio of the population living in urban areas. Hence, two factors are involved in the process: migration into the cities, or what you call rural-urban migration, and the natural or internal population increase in the cities due to excess number of births over deaths. Industrialization refers to a period of marked intensification of human trade and economic exchange due to factorial increase in productive capacities made possible by technological shift. Industrialization transforms an agricultural economy into a manufacturing economy. Historically, by creating economic growth and job opportunities, people are drawn to the cities. People tend to move to where opportunities are. They shift from rural areas to major cities as factories begin to pop up in urban centers, and this combines with the natural growth in the population. More opportunities mean greater economic possibilities, so people can afford to have larger families because they are able to earn more. Hence, urbanization leads to the growth of cities due to industrialization and economic development. According to the United Nations Population Division, the urban areas of the world are expected to absorb the entirety of the projected world population growth through 2050. Majority of this growth is expected to occur in less developed regions and countries, such that by mid-century, 54% of the world's urban population will be concentrated in Asia and 20% in Africa. There are four phases of the process. The first phase is the agricultural or primary production phase. The second phase is the acceleration stage or industrialization phase, characterized by exponential growth of the urban population and exemplified by third world countries. The third phase is the mature or post-industrialization phase, whereby urbanization tends to flatten up and stabilize, as seen in northwestern European countries, USA, and Canada. In the final phase, it is uncertain what will happen, but two scenarios are likely to happen. One, it will continue to increase until the country is 100% urbanized, as seen in Japan. That is, the process of urbanization continues for a much longer period as the area goes through several phases of economic and social reform after it's industrialized. It is not only a demographic movement, but also includes social, economic, and psychological changes. Or, second, large cities will lose their population and may witness a decline in urbanization, as exemplified by large western cities of London, Paris, and Amsterdam. Family sizes begin to shrink partially because family members became more expensive to maintain when they contributed to producing their food supplies. Family sizes began shrinking to become economically viable. The positive effects of industrialization on healthcare delivery are the following. There is easy access to health services through good infrastructure like roads. They provide transportation of individuals to the healthcare facility and ensure transportation of healthcare practitioners and their equipment to remote and marginalized communities to provide health. There is provision of essential machines like defibrillators, electrocardiograms, and suctioning machines, which are used for diagnosing and treating diseases. Industrialization facilitated study of different causes of disease and their modes of transmission for timely prevention. There is enhancement of better communication between healthcare providers and their colleagues and patients, thus facilitating healthcare delivery. As to the negative effects, industrialization led to migration of people from rural areas to urban regions, leading to overpopulation and overcrowding. The influx of people looking for work and the natural growth of families placed a major strain on existing resources such as housing and basic services. It has also led to poor healthcare delivery due to the increase in the number of population more than healthcare workers. Pollution in rivers and water bodies and in the atmosphere has led to cancer and respiratory diseases and spread of other diseases. Urbanization disproportionately impacts the poor due to unfair distribution of resources. This has led to a socio-economic divide, and people living in certain areas don't get access to health care. Urbanization as a negative effect has resulted in the following: inadequate housing and transport, poor sanitation and waste management, poor air quality, other forms of pollution like noise, water, and soil contamination, increased demand for unhealthy processed foods, vulnerability to climate change because of the increase in greenhouse gas emissions. The World Health Organization response to the effects of urbanization confer an approach that must be strategic, multi-sectoral, and coordinated, taking into consideration air quality, water and sanitation, urban planning, mobility, safety, healthy food systems and diets, environmental management of vector-borne diseases, and emergency preparedness and response. The second negative effect is pollution. Specifically, air pollution is one of the greatest environmental risks to child health in 2019. 99% of the world's population was living in places where the WHO air quality guideline levels were not met. Ambient or outdoor air pollution is estimated to have caused 4.2 million premature deaths worldwide in 2019. Household air pollution results from cooking, using open fires, or inefficient stoves fueled by kerosene, biomass, such as wood, animal dung, and crop waste, and coal. The combined effects of ambient air pollution and household air pollution was associated with 6.7 million premature deaths annually, and some 89% of those premature deaths occurred in low and middle income countries, and the greatest number in the WHO Southeast Asia and Western Pacific regions. These are the most common pollutants in the atmosphere. Particulate matter is a common proxy indicator for air pollution. There is strong evidence for the negative health impacts associated with exposure to this pollutant. The major components of particulate matter are sulfates, nitrates, ammonia, sodium chloride, black carbon, mineral dust, and water. Carbon monoxide is a colorless, odorless, and tasteless toxic gas produced by the incomplete combustion of carbonaceous fuels such as wood, petrol, charcoal, natural gas, and kerosene. Ozone at ground level is not to be confused with the ozone layer in the upper atmosphere, and it is one of the major constituents of photochemical smog, and it is formed through the reaction with gases in the presence of sunlight. Nitrogen dioxide is a gas that is commonly released from the combustion of fuels in the transportation and industrial sectors. Sulfur dioxide is a colorless gas with a sharp odor. It is produced from the burning of fossil fuels, coal and oil, and the smelting of mineral ores that contain sulfur. As to health outcomes, WHO estimates in 2019 state that some 37% of outdoor air pollution-related premature deaths were due to ischemic heart disease and stroke. 18% were due to chronic obstructive pulmonary disease, 23% due to acute lower respiratory tract infection, and 11% of deaths were due to cancer within the respiratory tract. The use of clean technologies that reduce industrial smokestack emissions, lean fuels and technologies to reduce household air pollution, shifting to low-emission vehicles and fuels, improving energy efficiency of buildings and homes, use of renewable combustion-free power source such as solar, wind, or hydropower, strategies for waste reduction, separation, recycling, and reuse have proven successful in reducing air pollution. Locally, we have the following government regulations and programs to reduce air, water, and solid waste pollution. The Clean Air Act of 1999, or Republic Act 8749, provides for the creation of a national program of air pollution management, and it has the Intensified Environmental Protection Program on Clean Air with the following sub-programs on motor vehicle emission, Industrial Emission Management Program, and the Roadside Ambient and General Ambient Air Monitoring. The Clean Water Act of 2004, or Republic Act 9275, provides for a comprehensive strategy to address the degradation of our water bodies, and it has for its activities monitoring of the compliance of firms or industries, conduct of classification of water bodies, and designation of water quality management areas. The Ecologic Solid Waste Management Act of 2000, or Republic Act 9003, provides for a systematic, comprehensive, and ecological waste management program to ensure protection of public health and the environment, and has for its activities closure of dump sites and establishment of material recovery facilities. Other negative effects are transmission and spread of communicable diseases and occurrence of non-communicable diseases, road traffic injuries, violence, and mental health. We start with communicable diseases. The rapid migration of people to cities can lead to overcrowding, lack of access to safe drinking water, improper sanitation, and inadequate waste disposal and sewage facilities. All of these shortages can be a threat to the residents' health and be a possible breeding ground for infectious diseases such as waterborne diseases like cholera, typhoid, and dysentery, water-wash diseases, and foodborne illnesses. In addition, poor housing, inadequate water supplies, sanitation, and waste management contribute to a favorable setting for vector proliferation such as rodents and insects which carry pathogens. The environment in urban cities has proven to be favorable for the rat population, and close encounters between rats and humans has led to the transmission of zoonotic infectious diseases such as leptospirosis. The trend in urbanization has shifted some infectious diseases which have traditionally been perceived as rural to urban settings such as the neglected infectious diseases like lymphatic filariasis. Malaria can be an urban health concern because of the presence of open wells and poor sanitation in slum areas which may provide opportunities for water to pool and consequently for malarial vectors to breed. Dengue is primarily urban, where its vectors thrive in overcrowded areas with poor sanitation and presence of human solid waste reservoirs for mosquitoes that transmit the infection. The sometimes uncontrolled growth of cities pushes residents to untouched ecosystems when new housing expands and infectious diseases can be introduced to these growing urban environments. Pathogens which adapt to urban environments from rural settings can spread in a more rapid manner, one of which is the Ebola virus disease, which had a profound impact on the world in 2014. This was introduced into the human population through close contact with blood, secretions, or other bodily fluids of infected animals such as fruit bats, chimpanzees, and monkeys found ill or dead or in the rainforest. When migrants from rural areas bring livestock with them to the urban centers, often in slum areas or shanty towns, vector ecology is also affected, such as in the cases of leishmaniasis spread by sandflies. The density of inhabitants and the close contact between people in the urban areas are potential hotspots for rapid spread of respiratory infectious diseases such as tuberculosis, pneumonia, severe acute respiratory syndrome, and the avian flu. Such environment can be potentially conducive for the development into a worldwide health crisis such as the COVID-19 pandemic. Urbanization may influence behaviors that affect the risk of acquiring HIV and other sexually transmitted diseases, including alcohol and drug use, as well as sexual behavior. Migrants to urban areas are often young people who are separated from their families and traditional social structures. In addition, other topics that merit further consideration on the urbanization and global health agenda are bioterrorism, nosocomial infections, and the development of resistant organisms. Development of health systems should be in parallel with improved housing, sanitation, and access to clean water. Vaccination, monitoring, and reporting of new cases are crucial. Among the non-communicable diseases, cardiovascular diseases account for most NCD deaths, or 17.9 million annually, followed by cancers at 9.3 million, chronic respiratory diseases at 4.1 million, and diabetes at 2 million, including kidney disease deaths caused by diabetes. 77% of all NCD deaths are in low and middle income countries, and tobacco use, physical inactivity, the harmful use of alcohol, unhealthy diets, and air pollution all increase the risk of dying from an NCD. These are made worse by unhealthy living and working conditions resulting from inadequate green space, noise, urban heat, lack of space for walking, cycling, and active living. NCDs threaten progress towards the achievement of sustainable development by 2030, which includes a target of reducing the probability of death from any of the four main NCDs between ages 30 and 70 years by one-third by 2030. Poverty is closely linked with NCDs. The rapid rise in NCDs is predicted to impede poverty reduction initiatives in low-income countries, particularly by increasing household costs associated with healthcare. Vulnerable and socially disadvantaged people get sicker and die sooner than people of high social positions, especially because they are at greater risk of being exposed to harmful products such as tobacco or unhealthy dietary practices and have limited access to health services. Also, in low-resource settings, healthcare costs for NCDs quickly drain household resources. The prevention and control of NCDs require a comprehensive approach, including sectors on health, finance, transport, education, agriculture, and planning. The key components of response include detection, screening, and treatment. A detailed discussion on NCDs will be given in a separate lecture. We now go to injuries, especially road traffic injuries. Approximately 1.19 million people die each year as a result of road traffic crashes. Road traffic injuries are the leading cause of death for children and young adults aged 15 to 29 years. 92% of the world's fatalities on the roads occur in low and middle income countries. More than half of all road traffic deaths are among vulnerable road users, including pedestrians, cyclists, and motorcyclists. Road traffic crashes cost most countries 3% of their gross domestic product. Economic losses to individuals, their families, and to the nation as a whole arise from the cost of treatment as well as lost productivity for those killed or disabled by their injuries, and for family members who need to take time off work or school to care for the injured. Local statistics show that road traffic deaths increased by 39% from 7,938 deaths in 2011 to 11,096 deaths in 2021. In 2020, the number of deaths was 8,746, and this is likely due to the reduced mobility of the population during that year because of the COVID-19 pandemic. In 2021, the number of deaths again increased to 11,096, coinciding with the end of lockdowns and mobility restrictions. The same with global statistics, road traffic injuries are the leading cause of death among Filipinos aged 15 to 29 and the major killer among children. And road traffic injuries cost about 2.6% of the country's gross domestic product. Who are at risk? Two-thirds of road traffic fatalities occur among people of working age 18 to 59 years. Males are typically 3 times more likely to be killed in road crashes than females, and more than 90% of road traffic deaths occur in low and middle income countries. An increase in average speed is directly related both to the likelihood of a crash and to the severity of the consequences of the crash. The risk of traffic crash increases significantly when the driver's blood alcohol content is more than or equal to 0.04 grams per deciliter. Non-use of motorcycle helmets, seat belts, and child restraints places one at risk for road traffic injuries and deaths. Distracted driving caused by a mobile phone is a growing concern. Drivers using mobile phones are approximately 4 times more likely to be involved in a crash. Unsafe road structure refer to inadequate footpaths, cycling lanes, safe crossing points, and other traffic calming measures. Unsafe vehicles necessitate requiring vehicle manufacturers to meet front and side impact regulations to include electronic stability control to prevent oversteering and to ensure airbags and seat belts are fitted in all vehicles. Inadequate post-crash care, such as delays in detecting and providing care for those involved in a road traffic crash, increases the severity of injuries. And inadequate law enforcement of traffic laws on drink driving, seatbelt wearing, speed limits, helmets, and child restraints. The prevention and control of road traffic injuries require a multi-sectoral approach to include transport, police, health, and education, as well as the private sector and civil society organizations. The United Nations General Assembly has set an ambiguous target of having the global number of deaths and injuries from road traffic crashes by 2030. By incorporating road safety features into land use and transport planning, improving the safety features of vehicles, enhancing post-crash care for victims, setting and enforcing laws relating to key risks, and raising public awareness. Locally, we have the Philippine Road Safety Action Plan 2023 to 2028, which serves as the blueprint for the country's road safety initiatives and seeks to reduce the number of road traffic deaths by 35% in 2028. It has five pillars. The first pillar, which is on road safety management, highlights the need for strengthening the Department of Transportation as the lead agency for road safety and advocating for adherence to applicable international agreements and adoption of global best practices on road safety. The second pillar, on safer road, tackles safety in infrastructure design, construction, operation, and maintenance. The third pillar, on safer vehicles, focuses on enhancing vehicle registration and inspection systems and compliance to harmonize vehicle standards and regulations. The fourth pillar, on safety road users, emphasizes increasing public awareness and support for road safety through media and communications. And the last pillar, on post-crash response, focuses on improving access to pre-hospital care, trauma care, and rehabilitation for victims of road crashes. We now go to a discussion on violence, specifically violence on women, children, and the elderly. Violence against women, particularly intimate partner violence and sexual violence, is a major public health problem and a violation of human rights. Intimate partner violence refers to behavior by an intimate partner or ex-partner that causes physical, sexual, or psychological harm, including physical aggression, sexual coercion, psychological abuse, and controlling behaviors. Sexual violence is any sexual act, attempt to obtain a sexual act, or other act directed against a person's sexuality using coercion by any person regardless of their relationship to the victim in any setting. It includes rape, attempted rape, unwanted sexual touching, and other non-contact forms. Violence can negatively affect women's physical, mental, sexual, and reproductive health and may increase the risk of acquiring HIV in some settings. Violence against women is preventable. The health sector has an important role to play to provide comprehensive health care to women subjected to violence, including referral to other support services. In our setting, data on violence against women from the 2022 National Demographic and Health Survey show that 1 out of 5 women have experienced some form of violence by their current or most recent husband or intimate partner. In 2023, 8,055 cases of violence against women were reported to the Philippine National Police. The following are the risk factors for both intimate partner and sexual violence. Violence against women can have fatal outcomes such as homicide or suicide. Injuries may result as a consequence of this violence. It can also result to unintended pregnancies, abortions, gynecological problems, and sexually transmitted infections. It can lead to miscarriage, stillbirths, preterm delivery, and low birth weight babies. It can cause depression, post-traumatic stress, and other anxiety disorders. It can lead to headaches and pain syndromes, and it can also result to increased smoking, substance use, and risky sexual behaviors. Domestic violence in particular can have a profound impact on children by causing behavioral and emotional disturbances, mortality, and morbidity such as malnutrition and diarrheal diseases. In women, they may be unable to work and lose their jobs, feel isolated and disinterested in joining group activities, and will have limited ability to take care of themselves and their children. In 2019, WHO and UN Women, with endorsement from 12 other UN and bilateral agencies, publish Respect Women, a framework for preventing violence against women aimed at policymakers. Each letter of respect stands for one of the 7 strategies. For each of these 7 strategies, there are a range of interventions like relationship skills, strengthening and working with couples to improve communication and relationship skills, combined economic and social empowerment programs, provision of cash transfers to reduce poverty, provision of an enabling environment in schools by eliminating harsh punishment, prevention of child and adolescent abuse, and transforming the attitudes through group-based participatory education to change unequal gender norms. Locally, we have legislation for the protection of women and children, specifically Republic Act 9262, which is the Anti-Violence Against Women and Their Children Act of 2004, which seeks to address the prevalence of violence against women and their children by their intimate partners. The 2024 18-day campaign to end violence against women remains aligned with the United Nations Unite by 2030 to End VAW initiative, of which the Philippines is one of the 51 charter members. This is also in line with the commemoration of the 20th anniversary of the signing of the Anti-VAWC Act of 2004, or Republic Act 9262. Violence against children includes all forms of violence against people under 18 years old, whether perpetrated by parents or other caregivers, peers, romantic partners, or strangers. Experiencing violence in childhood impacts lifelong health and well-being. Target 16.2 of the 2030 Agenda for Sustainable Development is to end abuse, exploitation, trafficking, and all forms of violence and torture against children. Violence against children include maltreatment, bullying, youth violence, intimate partner violence, sexual violence, and emotional or psychological violence. Local data show that in 2022, 3 in 5 children aged 1 to 14 years, or 58.8%, have experienced at least one form of violent discipline. 7 out of 10 cases of child abuse reported through the Women and Children's Protection Units in 2012 to 2014 are sexual in nature. Online sexual abuse and exploitation of children is rapidly escalating. The most common form of domestic violence is emotional or psychological violence. Bullying in school remains a significant issue, and majority of working children are child laborers. Nearly 3 out of 5 were engaged in hazardous, exploitative, unhealthy, unsafe work in 2022, equivalent to some 828,000 children. Region 2, SCAR and BARMM have the highest share of child labor. Fear, low self-esteem, anxiety, depression, stigma, and affordability of child protection and mental health services affect help-seeking behaviors. Violence against children can result to death, severe injuries, impaired brain and nervous system development, negative coping, and health risk behaviors. Children exposed to violence and other adversities are substantially more likely to smoke, misuse alcohol and drugs, and engage in high-risk sexual behaviors, which can result to unintended pregnancies, gynecological problems, and sexually transmitted diseases. They also have higher rates of anxiety, depression, other mental health problems, and suicide. Children exposed to violence and other adversities are more likely to drop out of school, have difficulty finding and keeping a job, and at risk for later victimization and/or perpetuation of interpersonal and self-directed violence. Violence against children can be prevented. Under the leadership of WHO, a group of 10 international agencies have developed and endorsed an evidence-based technical package called INSPIRE, which contains 7 strategies for ending violence against children. The package aims to help countries and communities achieve SDG Target 16.2 on ending violence against children. Each letter of the word INSPIRE stands for one of the 7 strategies, and most have been shown to help preventive effects across several different types of violence, as well as benefits in areas such as mental health, education, and crime reduction. There is the Fourth National Plan of Action for Children, which is a strategic framework aimed to level up protection of the rights of children in the Philippines, including the most vulnerable, towards improving their lives. The child protection aspect of the NPAC aims to establish robust protection systems across the country, focusing on creating a safe, nurturing environment for children. Around 1 in 6 people 60 years and older experienced some form of abuse in community settings during the past year. Rates of abuse of older people are high in institutions such as nursing homes and long-term care facilities. Rates of abuse of older people have increased during the COVID-19 pandemic. Abuse of older people can lead to serious physical injuries and long-term psychological consequences. Abuse of older people is predicted to increase as many countries are experiencing rapidly aging populations. Risk factors for elder abuse can be grouped into individual, relationship, and community level factors. In a local study among urban poor communities, verbal abuse was the most common type experienced by older persons. Perpetrators are most often the children and other family members, and of those who experience abuse, only 2% reported the incident to the authorities. From the Coalition of Services of the Elderly, psychological abuse was the most common type, followed by financial or material abuse. The perpetrators have a particular profile. Low social support is the most common relationship level factor, and community level factors include urban residence and social isolation of the caregiver and the older person. Abuse of older people can have serious physical and mental health, financial, and social consequences. For older people, the consequences of abuse can be especially serious and recovery may take longer. Most of these interventions to prevent and respond to abuse of older people is limited at present. Strategies considered most promising include caregiver interventions, money management programs for older adults vulnerable to financial exploitation, helplines, and shelters. On June 15, 2022, World Elder Abuse Awareness Day, WHO and partners published Tackling Abuse of Older People, 5 Priorities for the UN Decade of Healthy Aging 2021 to 2030. These 5 priorities are combat ageism, generate better data to raise awareness of the problem, scale up cost-effective solutions to stop abuse, investment focusing on how addressing the problem is money well spent, and raising funds to tackle the problem. In terms of human rights of older persons, there is currently no legislation that specifically and explicitly addresses violence against older persons in general. There are, however, other laws that may cover violence against older persons, although not in a comprehensive manner. We have the Magna Carta of Women. We also have the Anti-Violence Against Women and Children Act. However, this law only applies to violence in the context of family, environment, and intimate partnerships. And we have the revised penal code that penalizes the commission of crimes against persons. And acts of violence against older persons may be considered criminal acts under the revised penal code. There is also no systematic reporting and monitoring mechanism at the national level for acts of violence against older persons. In line with the Philippine Plan of Action for Senior Citizens 2012 to 2016, which stated that there is a need to establish a reporting system and intervention to address the issue, the DSWD pilot tested a project dubbed as Reporting System and Prevention Program for Elder Abuse Cases, or RESPECT, which aims to protect the rights of older persons against all forms of abuse through the establishment of local reporting mechanisms and access to necessary services for their full rehabilitation and recovery. This pilot project ran from 2016 to 2018 in 4 island clusters, namely San Carlos, Pangasinan for Luzon, Lambunao, Iloilo for the Visayas, Maco, Compostela Valley for Mindanao, and Valenzuela City for the National Capital Region. It also created the Protection Committee for Senior Citizens at the barangay and a Barangay Senior Citizens Information and Reporting Desk to fully implement the reporting system for elderly abuse cases in the community. The last of the negative effects of industrialization on healthcare delivery is with reference to health inequalities. Rapid and unplanned urbanization can have many negative social and environmental health impacts, which hit the poorest and most vulnerable the hardest. In many cities, the poor can find it difficult to access proper health care due to the cost of such services. The last few slides will touch on topics of growing public health concern that are also related to urbanization, such as mental health, international travel, and climate change. Urbanization affects mental health through social, economic, and environmental factors. The risk of developing depression, which is the most prevalent mental disorder in the world, characterized by low mood and feeling helpless, is 20% higher in urban dwellers than those who live outside the city. The risk of developing psychosis, which is a severe psychiatric disorder associated with hallucinations, delusions, paranoia, and disorganized thought, is 77% higher in urban than rural dwellers. The risk of developing generalized anxiety disorder, a state of mind characterized by feeling anxious in a sense of impending danger or panic, is also 21% higher in urban than rural areas. Anxiety and depression are more prevalent among urban women than men and are believed to be more prevalent in poor than in non-poor urban neighborhoods. WHO analysis also documented a close association between the prevalence of violence and women's mental health. Epidemiologic studies have identified a large number of factors. Social risk factors for mental health in cities include low socioeconomic status due to low educational level and income, low social capital because of low social support and efficacy, and social segregation resulting from perceived minority status or ethnic group membership. Similar patterns can be found for urban physical environment, such as higher rates of air, water, and noise pollution, specific urban designs, such as tall buildings that may be perceived as oppressive, or more physical threats from accidents and violence and overcrowding, which likely increase stress levels. A systematic review of 39 studies and a meta-analysis carried out in 2021 indicates that there is a link between depression and long-term exposure to particulate matter and short-term exposure to other pollutants such as nitrogen dioxide, sulfur dioxide, carbon monoxide, and ozone. Analysis of data from US and Denmark indicate a significant association between exposure to air pollution and risk of neuropsychiatric disorders. Research also indicates that living close to major streets or airports increases exposure to traffic noise and pollution and is associated with higher levels of stress and aggression. Under urban design exhibits, greater access to green space and better walkability was associated with less depression and enhanced physical activity. Urban green and blue features additionally have the capacity to buffer urban heat island effects and to reduce heat stress. From Health and Environment Alliance, these are some of the features of a mental health friendly city. International tourist arrivals have shown an exceptional growth from 25 million in 1950 to 1,087 million in 2013 and is expected to be 1.8 billion in 2030, according to the World Tourism Organization. Air travel has expedited the movement of airborne pathogens, and viruses can now travel across the world within 24 hours, allowing regional epidemics to become global pandemics within a matter of weeks or even days. SARS emerged as a global threat in 2003, and the example of SARS shows that the infection can spread throughout the world by international travel, and so did COVID-19 in 2020. The zoonotic disease dengue is endemic in most tropical and subtropical regions, which often are also popular tourist destinations. Travelers to endemic countries can contribute to the spread of the disease. The number of dengue cases imported into Europe is highly correlated with the number of travelers arriving from endemic zones. The global rising problem of antibiotic resistance has also been linked to international travel, such as certain antibiotic-resistant Staphylococcus aureus and fecal colonization with extended-spectrum beta-lactamase-producing Enterobacteriaceae. Global travel shows no signs of decline, and the interconnected megacities around the world make global surveillance even more important when it comes to contagious infectious diseases. Extreme weather events will maintain the endemic status of diarrheal diseases. Chronic respiratory and cardiovascular diseases are strongly influenced by increases in temperature. It is expected that vector abundance, survival, and feeding activity will increase with increasing temperature, as will the rate of development of the pathogen and transmission season. These are my references, and thank you for listening.